welcome to my channel. So for those who are new to my channel, my name is Manny and I am an ICU nurse educator. I have been a nurse for 30 years, ICU, and I'm here to share some of the techniques on how can I guide you to survive with this type of business. So for those nurses who've been a nurse for more than 20 years, it's always nice to ask yourself, oh my God, how did I survive in nursing? Because to tell you honestly, it's not easy, right? It's hard. I mean, there's a lot of technical, critical thinking, physical aspect of what we do. You turn, you pull, you prevent patients from falling. So pretty much there's like a constant movement, especially in the ICU. And when you critically think at the same time you're doing it. So just like they actually compared it to a carpenter, a joiner. So they're thinking, they're measuring, they're doing physical stuff. All right. So today I'm gonna share some of my experiences. How did I survive nursing for more than 30 years now? So I graduated in 91, and after graduation I worked in the ICU or in the hospital acute settings. So since then I never worked anywhere other than ICU, and now as an ICU nurse educator and in and out management. So nursing workflow for beginners. So I'm hoping that this will help you. So if you're a nursing student who's looking for ideas, how to, what do we do, what do nurses do at the bedside, then you come to the right site. So just listen to what I'm going to share you. I normally just share all my experiences and what I say or what I share when I'm teaching also. So here, nursing workflow for beginners, and then there's a lot of topics in here along the way, and we would discuss that. Okay, number one is nursing orientation. So to tell you honestly, before you get into nursing orientation or general orientation, you need to pass the interview, right? So something that I want you to understand is during interview, you have to think of selling yourself. So if I'm the manager, why will I hire you? Because there's so many nurses, for one position, there are gonna be like 100 applicants, especially those new grad training program. So I used to run that program, and I get hundreds applicants, and then we interview them and pick which one is the best or who are amongst the 100. If we only need 6, then that's really a very tight position for everybody, because it's hard to choose. Out of 100 you only need 6. So again, if that's something that you need some mentorship, guidance before you graduate your nursing, or if you already graduated and looking for a job, if you're coming from a different country, just like me, I came from the Philippines and then I work here in the United States, but they hired me over there. So when I came here, I already have a job. However, when I transition to another hospital, you go through the process. You have to be interviewed. And I remember I only highlights whatever that I want them to hear. If the question is about strength and weaknesses, then that's something that it become, tell them honestly what is your weaknesses. If it is English, speaking English, or being sensitive and emotional, those kind of things. Or if you are really dedicated that it impedes your workflow because you spend most of the time with the patient and doing patient's interaction, things like that. So good luck. And then if you made it, then you go to a general hospital orientation. So general hospital orientation includes HR, human resources, talking about the mission and vision of the hospital. Where are the policies and procedures located at? Some of the Joint Commission requirements that you need to know. So what I noticed that most of the new nurses, when they're novice or new grad, they tend to be clueless about the Joint Commission, because what do we normally do if the Joint Commission are in the hospital and there is a student? They send the student home, right? So therefore, they will not have any idea how do they do the Joint Commission survey. So, as an educator myself, that's one thing that I teach them. What would be the possible questions that a Joint Commission surveyor might ask, this new staff? So again, if you are a nurse educator, you need to think about that. Find time to teach your new nurses about national patient safety goals. Incorporate that in your nursing orientation. So the next one is nursing orientation. So again, guys, there's so many different ways to orient nurses. I have been to a lot of hospitals that does or do differently from one hospital to another hospital. So then, of course, realistically, what is really the desired or the perfect nursing orientation? Some, when you surveyed these nurses, they might say, "Oh, boring. We're just sitting there and listening." So we learned that we have to shift the attention or the focus from the teacher to now the learners or the nurses, right? So learner centered, meaning you get their opinion, you get their input about that topic. So they're pretty much like encouraging them to speak more, and you just have to listen. That's what I do. I listen, and then I just have to verify or clarify something that I think it's not correct, or there's a room for improvement, things like that. And then when you're done with your nursing orientation, in my unit we give tests. So we test the nurses with mathematics, pharmacology tests, EKG tests, basic knowledge assessment tests, hemodynamic tests. So this is in the ICU setting. So if you're joining us, if you came from med-surg, we're still going to give you that test to find out how much do you know. So in order for us to address some of the gaps, and we go from there. So I don't expect everybody to pass the BCAT, the Basic Knowledge Assessment test, but it gives me some guidance and at least idea what are the things that you need to focusing on. Because sometimes you might be good in EKG interpretation, but you're not good in hemodynamics, things like that. And clinical preceptorship, you're gonna be working with your preceptor. So what does preceptor do? It makes or breaks your nursing career, and that's the truth. So if you think like your preceptor is not it's not matching your personality, or you don't feel supported, you do not wait the last minute. So you need to involve your manager and say, I'm requesting for another preceptor. Why did I say that? It is because I found out that it can actually set you up for failure, to fail. And as an educator myself, we normally, meet with the preceptee and preceptor every 4 weeks, 8 weeks, and then 12 weeks. If we identify an issue, we'll do it every week. So we use the daily progress evaluation tool, DPET. So daily progress evaluation tool is something that guides the preceptor in quantifying, not qualitative, not how you feel, but quantifying your skills and your critical thinking and your behavior. So the KSA, knowledge, skills, and the ability and competency, KSAC. So those are the models that we use for nursing orientation. Okay? So you expect that when you come to the hospital, you do all these things. So your clinical preceptorship, your relationship with your preceptor should be very, very good. So what are the things that you need to use? I call it tools to use. Your brain, so your nursing brain, wherein it guides you systematically on on how to assess your patient when you get your report. So neuro, CV, pulmo, GIGU, musculoskeletal, then your laboratory, and then your to-do list. So that is in your nursing brain, and you do not want to lose that. You want to keep that. You have your binder, or there's something that you can buy that you can fold. So if you have that, good. Invest on something. You can use that forever as long as you're working at the bedside. It's really helpful that you can organize your work that way. Okay. If you don't have any tools, you can create one. You can Google it. So mine is, I normally create my own because I don't want to write a lot. I just have like a picture diagram. If they're telling me NG tube, I will put NG tube. They're telling me blood IV on the right arm, it's purely a diagram, leveling or labeling it. So when I look at it, I know where my IV sites are: central line, Foley, rectal tube, things like that, PA catheter. All right. So that is your tools, your nursing brain. And also it tells you what are your to-do lists. So the to-do list is, there is a checkbox. If I checked it, that means I already done it, so that I don't keep repeating and checking it again, because it's going to be a waste of time, right? So you don't want to waste so much time. Again, what I want you to remember is to work smart, not work hard. Okay? So it's an opportunity for you to assess yourself in how you organize your work. And then you have your lab results in there. So making sure that when you get report, you check your labs so that you can ask question to the outgoing shift. If what time was that abnormal lab? Was it communicated to the doctor? For example, potassium. Sometimes at night shift, they draw it between 3 in the morning and they get the result at 4. So did they already call the doctor at 4 when they got the result? Because if not, and if they waited for you, although nursing is a 24/7, but imagine you're going to be chasing all this potassium. You can only run 10 mec. 10 milli equivalent peripheral IV times 1 hour. So if there's an order for 60 and you don't have a central line, that's 6 hours. It's a killer. And it's going to make your day really busy. All you did was hanging potassium, and it's very painful for the patient. So might as well just get a PO. Potassium ordered, right? It's the same. I mean, some of our K-Dur now or elixir is to say it's going to be absorbed fast. rather than waste putting it in the IV. And I don't get it why the doctors love to put it in IV when you can have PO. And it's faster that way, especially if you're giving Lasix. By the time you replace it, the patient already peed it out. So might as well just get it PO so you can give everything PO. That's just my 2 cents. All right. And then when you're doing your assessment, again, this is something that I want you to think about. Because when I ask the nurses, how do you assess and how many minutes will take you to assess or do your assessment? In the ICU, you have 2 patients. In med-surg, you have 4 or more patients. And then in progressive care, you have 3 patients. That's step down. And in the ED, I think you have 2, depending on patient's flow. On the SNF, you have 10, I think, or better yet, you have everybody. And then you have an LVN or LPN. All right. So when you're doing your assessment, and if this is something that you struggle, I want you to reflect and assess yourself. How fast can you do your nursing assessment that you won't miss anything? When you say nursing assessment, make sure that it's effective nursing assessment. What makes it effective? Well, it's accurate. So you know what you're saying. You know what you're telling your colleague or the doctor. If you say Foley, patient should have Foley, right? So that's why I don't understand why nurses will give report at the bed. No, in the nurse's station away from their patient. I don't recommend that. I recommend that you get report at the bedside so that if the outgoing nurse is telling you Foley, you look at your patient if there's a Foley, and if there's Foley catheter, then yeah. So you can see what I mean is that you can see whatever they're telling you. Central line, right IJ. Is it in the right IJ? Sometimes they said central line, left IJ, but then when you go to the bedside, it's on the right. So those are not accurate. So if you're telling me it's in the left, but when I go there, it's on the right, then you're not really telling me the truth, right? So that's not good. So I want you to do it at the bedside so that you listen, you look, okay? And I want you to listen first. Don't question, don't interrupt until after the report. That's why you need to write down on the side your question, because some nurses are very short attention. So especially if they already had a long day, they just want to tell you whatever that happens. So ask question after. If she's done giving your report, then she will ask you, do you have any question? That's when you ask. Don't interrupt. It's just a courtesy, right? How do I do 5 minutes head to toe? So again, I want you to understand that when we are assessing our patient, we're looking at cranial nerves, right? Responses, mental alertness, skin integrity, right? Contraptions, central lines, Foley, J. Pratt, Jackson Pratt, Hemovac, those kind of things, epicardial wires. So those are part of your assessment. Neuro checks is, something that we always start. So ask Mr. Smith, how are you? Can you tell me? Or sometimes I ask them, can you tell me your name, please, sir? And then they tell me their name. Do you know what date today? So they tell me the date. Who's the president today of the United States? Then they tell you. So that is checking your alertness, orientation, things like that. And if they are looking at the whiteboard, make sure that your whiteboard inside the patient's room is accurate. So the clock should be correct time. Your date is supposed to be correct. Your name is supposed to be written into the whiteboard. Okay. And then you ask a patient, can you raise your arms up? Okay, so you count 1 to 10. Okay, because that's the standard neuro checks. And then you shine a light, right? You shine a light in their eyes. You're looking for constriction or vasodilation, pupillary dilatation. So what do you do there? As far as I can remember from my nursing school, I always want you to think, when you're thinking about your neuro checks, so I always think about the happy face, right? Okay, so let me erase this, guys, because I need this space. So I'm gonna put a happy face here. Okay, this is your happy face. So this is your eyes. Okay, so when you're looking at your cranial nerve 3 to 4, so you're shining a light, you're looking for pupillary response, constriction, then it went back to normal shape, or they're dilated like that. It tells you the healthiness of your, okay guys, it's that midbrain. Okay, the midbrain, or the midbrain, yeah, right. And then after that you have your pons, right? And then after that you have your medulla. Okay, so these are the 3 parts of the brain stem that I want you to focusing on. So cranial nerve 3 and 4 talks about the healthiness of your midbrain. When you're checking those pupils with lights constricting, or if they're pupillary dilated like that, they're not moving, fixed and dilated, that's cranial nerve number 3. Then you think about your midbrain. Is it intact? Is it still healthy, or it's gone? Okay, so when you're checking eyes that are going in, okay, that's 4. And if you're asking your patient, follow my finger side to side, right? You follow it like that. That's your 6, pretty much. Cranial nerve number 6. So what you're doing there is checking this with your, pen light, asking them to follow, looking at my finger, follow to the nose or side to the side. That is 3 on the eye. That is 4 when you say follow my finger, put it in the nose, because the pupils is going in. And on the sides up and down, that is your 6. So cranial nerve 3, 4, and 6, right? Okay, so where's it? 3, 4, and 6. Then you're gonna go by checking the cranial nerve number 5, so trigeminal. So there is that zone 1 here, 2, and 3, right? So you put your finger like this to see if they're having some pain. Sometimes you touch them like that. So if they have some pain during touch, when you're touching their face and they're grimacing, so now we're talking about the pons. Okay, so I would put it this way. So there is the nose. So you're 5 to 8. Okay, so your cranial nerve 5 to 8, it talks about the healthiness of your pons. Okay, so think about your 3 as in the midbrain, think about your 5 is in the pons, and think about your 10 is in the medulla. So 3, 5, and 10, they are pretty much like within those, into that, centered into the brain, midbrain. Of course, cranial nerve number 7 is like a 7, like a hook. So when you pull that hook, you have your facial drooping, right? So when they have a stroke and the facial droop like that, that is your cranial nerve number 7. Okay. So then you have your mouth. Okay. So this is when you're testing them for, tell them to open their mouth. So if you see them, if you use a tongue depressor, say if the uvula goes up, that is cranial nerve number 9, and the gag, and then it gags, that cranial nerve number 10. Okay, and then you ask them to stick up the tongue, that is move it to side, that is cranial nerve number 12. Okay, so again, the gag, the response to gag or just moving the uvula, the back of your throat is 9. Then when they're gagging, it's 10. And then when they're sticking out their tongue, it's 12. And then the 11 is just like when you tell them to shrug like that, So that is your 11. So what you're doing there is you're checking the healthiness of the medulla. All right. So when you did that, that is a very fast neuro checks, right? And then you move down, get your step. And then I just kind of asked them to lift the leg. So 1, 2, 3. If they raise their right leg first, 1, 2, 3, 4, 5, down. Then the left leg, 1, 2, 3, 4, 5, down. If they're good, you don't have to worry about it. But if you think like they're coming in with neuro issue, then you would like them to do the shin, like let your right heel rub it or just slide it on top of your shin, left shin, things like that. So you do that also. And then you go to your CV. Okay, look at, expose the chest, remove the gown, then look at the chest for any scar, previous surgery, open heart, things like that, or anything. If you see any scar there, you have to ask the patient, right? Then you put your stethoscope and listen for that lub-dub, lub-dub, lub-dub. S1, S2. Okay. And then you listen to the chest lung sounds. Okay, you put your stethoscope. So that's what you learn with. I'm hoping that you do your you do your assessment checks with your preceptor, so that your preceptor can validate you if what you're doing is correct. Okay, because we need to validate that your assessment skills is actually good. All right, and if your preceptor agreed that you did well, then good. So that's 5 minutes head to toe assessment. Again, guys, your prioritization, so that's something that eventually you will learn from your preceptor. So you need to see and ask how your preceptor able to go home on time. Some nurses or some new nurses, that's why I always tell them is that you need to learn the technique why your preceptor able to go home on time, if they're 12 hours or if they're 8 hours, right? So what do? What are their strategies and techniques in like putting their workflow together? So for you to take note, and if that's something that you like, then use it. So the good thing about it, and some nurses don't like to have multiple preceptor because they feel like it's too much, they're not learning, it's constantly changing. To me, I like that. I like the idea that I have a multiple preceptor because I see one style to the other, and then if I like them both, I put them together. So it's an opportunity to learn, right? So your preceptorship is not just to prepare you to learn the basic requirements to work in that unit, But in order for you to also build and get ideas from them, okay, how did they start their day, and then what do they do next, okay, so that's fall under your prioritization. We always ask staff, how do you prioritize your work? So you start from looking at your patients after you do your report, right? So you got report, and then you don't have any more question. The night shift went home. Then you go to see your patient, you do your walking rounds. So hopefully you did it at the bedside so you can introduce yourself and then write your board, right? So that's why I like giving report at the bedside, because after the report you already know which one needs priority. So if bed 1 is sicker, then bed 1 is your priority, okay? So things like that. But if they're both higher acuity, so you do your ABC. So airway, breathing, and circulation. Okay, so who has the issue about airway? Is this guy desaturating because ARDS? Then take care of that patient. Make sure that you delegate or ask the RT. So if I have that situation, I normally get the RT to take care of the airway, because that's their, that is their ventilator. And then I go to my other patient, which has same situation. If there's circulation problem like blood pressure issue, then I go to the next door. So again, guys, it's delegation. Okay, time management. So your brain should at least assist you with your time management, so that there are, it guides you. If it's time for blood sugar check, it's time to empty the CBI, continuous bladder irrigation, it's time to recheck factor 10A or ACT, those kind of things. It's time to check chest tube, it's time to check pacemaker, the safety margin checks. So that's what I want you to think about. And we always ask you guys, during check-in, we always ask if these are something that is improving or not improving. Okay, so that's just my 2 cents. I want you guys to understand. So hemodynamics monitoring, again, guys, it's really important that you understand. The more you understand your hemodynamics, the more that you can effectively care for your patient, right? If you're telling me what is systolic blood pressure means to you, and what is diastolic blood pressure means to you. So let's say 120/70. Okay, so 120/70, we all know it's normal, so I don't have to worry about it, right? However, after 1 hour, it becomes 80/60. So the issue is systolic or diastolic? Correct. It's systolic blood pressure. Okay. So systolic blood pressure is pretty much like a stroke volume. So probably this patient is dry. So you give him, again, PLR, passive leg raise. Do it first to see if your patient is fluid responsive. If they're not fluid responsive, that means you did a PLR, nothing happens. Then you need pharmacology, right? So you need some vasopressor or vasoactive drugs that we do in the ICU. So preload are your CBP and PAOP. Okay, so your CBP is your right-sided preload before the heart. So blood that are the superior vena cava, inferior vena cava will go to the right atria is your CBP. And the PAOP is before the left atria. So they came out from the heart, up from the lungs, to now going to the left atria. So you only use PAOP for a PA catheter. If you have that, we used to call it Swan-Ganz catheter. But if you don't have a PA catheter, you don't have a way of knowing the PAOP. So you got stuck on CBP, especially if it's just a central line. However, you always think about, a good RN should know what are the normal parameters for CBP, 2 to 6, and 8 to 12 here if you have a PA catheter, right? So you should know when it's low and when it's high. So CBP, a low CBP might indicate, a low CBP might indicate, I always say low dry, right? And then high CBP is wet. Okay, so think about this, guys. However, there's a lot of research out there that CBP is not really an accurate measurement for volume, because it's just kind of measure the upper portion where, the superior vena cava. What if your lower extremities are dry, right? So CBP is, we just use it as a guide, but I don't want to treat patients based off CBP because we have a better technique other than CVP, right? Just like echo, for example. When you're doing ultrasound of the IVC, so the inferior vena cava, so when they ultrasound that, they're looking for not collapsing. So the diameter of your IVC, if it remains good, normal, but if it start collapsing, so then your volume is probably not enough. So your patient probably needs more volume, especially if they're low blood pressure. Okay, so we can only do that when we use ultrasound. So usually the doctors, I normally ask them, I say, hey, I just gave normal saline bolus, and I'm not sure if he needs more, because again, I don't want to use blood pressure as my parameter that the treatment was effective, or the CBP, so sometimes I just tell them, I know that my CBP now is 6 and my blood pressure went up to 110/70, but I still want you to check the IVC, inferior vena cava, because if they're collapsing, the fluid is not enough. And that is actually true. It backs up with evidence and research. So if your doctor don't want to do that, then just document it. I want the nurses to be at least advocating for patient safety. That is a technique to be able to assess the patient for fluid status. Why not use it, right? So again, I'm sharing this information because I want you to be more effective. You're working with a lot of new doctors nowadays because we have a lot of doctors, very good doctors that retired, and now they're being replaced by, same way, like I call them a novice doctor. Let's face it, I know they went to medical school, but they're still novices. And being a nurse, like if you've been a nurse for a while, you know what I'm talking about. So you're dealing with another sets of doctors at the bedside that might need your help and guidance. So guide them, guys. If you are expert nurse, guide them with giving you a very good doctor's order. And then your afterload are your SVR for the left side, PVR for the right side. Okay, right afterload, and then left afterload, left side afterload. So when you're talking about afterload, and you're talking about systemic, this is longest. It's a very long from coming out from the left ventricle aorta to the system, and then they go back to, they're passing the pressure into the capillary system, and it goes to the venules, to the vein as a low pressure system, and then they go back to the right side. When the PBR, it comes out from the right ventricle to the pulmonary artery and to the lungs. So that is the start of your PBR, is when they go, when when you're measuring the pressure into the pulmonary artery and then into the lungs, okay, and then it comes out into the pulmonary vein to go into the left atria. So that is your PVR. So normally when you say PVR, you look at your PAP, pulmonary artery pressure, and you have your mean pulmonary artery mean minus, so you have to minus it with your PaOP, okay, and then you divide by 3, I believe. So there is a formula for that. So, but what I'm saying is that when you have a high pulmonary vascular resistance, high is tight, too tight. So too high, too tight, too low, too loose. Okay, so it's just for you to remember. If your PVR is, the normal is 250 to, let's say 250 to 400, and your PVR is 700 or 900, then it's telling you too tight, right? So what makes it tight? Either pulmonary hypertension, okay, pulmonary embolism, those kind of things, or there's a shunt. So same way with your SVR. So if your SVR is, the normal is 1100, so 800 to 1100, depending on the protocol of the hospital. Let's just say if you have 2500, that's a high SVR. It's telling you your patient is clamped, so too high, too tight. So what do? You have to give them vasodilator to dilate that, right? If they're too loose, you need to constrict it, vasoconstrictor. So again, guys, that is just an FYI. And then contractility, we go by cardiac output, cardiac index, right? So the doctor wants cardiac index better than cardiac output because it all depends on the body surface area. So BSA. All right. So I'm just sharing you the hemodynamics aspect of what we do in the ICU because you need to learn hemodynamics if you decided to work in the ICU. All right. Then we're gonna move on technical skills. Technical skills are something that you need to work on and improve over time because it can actually affect your workflow. So if you have a hard or no skills in IV insertion, it might be, unless your hospital has an IV team, then you can reach out to them and they will put one for your patient. But it could delay your treatment, especially if the doctors order a new treatment, let's say fluids or vasoactive drugs, and actually as long as it's brand new and it's 20 or higher, you can start your norepinephrine or Libofed until they put a central line. You do not wait for the central line to start your Libofed, right? Because your patient is becoming unstable. So you need to start the treatment right away. So you need to have an IV skills. So if this is something that you need to improve, then work on it. So what do we do? If we have a new nurse, and she needs to practice skills in IV insertion, we normally put them in like those nuclear med, like an outpatient settings, wherein they can actually insert an IV to all the patient. They will do a lot of IV insertion in there. They might put an IV 10 a case or 10 IV in a day. That's good. So that's one way. So if you're a preceptor and you know your preceptee that have or is a brand new nurse and she needs experience in IV insertion, that's what you do. Send them out to like nuclear med or radiology for what they, when they put an IV for IV or contrast So that's a good training for them. NG insertion. So if you're training a new nurse in the ICU and someone pulled out an NG tube or got intubated and they need to put an NG tube, make sure that you send your new nurse there so that she can experience it. So in the ICU, we don't do it in the nasal. We put it on the OG, especially if they're intubated, because we don't want any sinusitis. However, if you know that the patient will need a long-term feeding tube or tube feeding, because they might have some problem like ARDS, that's a long-term. So we use the KU feed, a smaller tube that is designed for long-term use so that they won't have any issues with sinusitis. Foley insertion is the same. Once your patient is intubated and sedated, you need to put a Foley because you don't want pressure ulcer or skin integrity, alteration in skin integrity. So you need to put Foley. Again, guys, Foley insertion is something that you need to justify the necessity on a daily use. Okay? If the patient is wide awake, he doesn't need it, pull it out. You don't want any coronary or catheter associated urinary tract infection. And also a lot of ICU armamentarium. What I mean by this are your balloon pump, ECMO, Impella, CRRT machine, that we attach to our patient other than the ventilator. So again, you need some training for that. We provide training for those, and how nurses, they run all this machine in the ICU. When you know everything, then you can actually work everywhere, anywhere in the United States or around the world. So that's something that I want you to think about when you're working in the acute, is the versatility, the experience that you get to run all this machine, and at the same time critical thinking. You need to align them together. Okay, and that's pretty much what I have. So how to use S-bar effectively. So when you're communicating with a doctor, we always say use the S-bar, right? So question, sometimes it depends on your level of confidence. So S-bar, so what is the situation? So sometimes we just tell the nurse, say the situation is low blood pressure, hypotension. Okay, Mr. Smith is hypotensive now. What happened to Mr. Smith? He came in yesterday from emergency room from a nursing home because of, say sepsis, pneumonia, and history of CAD, and stage renal disease, diabetes, right? Then now what's your assessment? Then tell them your blood pressure. So my blood pressure is 70/45. I did a PLR, passive leg raise. It went up to 120/70. Heart rate is 101. Vital signs. Then give the labs. So labs are hemoglobin, hematocrit, creatinine, things like that. Creatinine, or any white count issue that might be suspect of sepsis. And then your recommendation. So this is something that some of the doctors will come to me and say the nurses are underutilizing recommendation. This is where I say, how much do you know? Because if you're doing an S-bar, you should at least know something. What do you want from me? If I'm the doctor, what do you want from me? So do you want me to bolus? So hey, do you want normal saline 1 liter right now? I don't say, do you want saline 500 or 250? Ask for 1 liter. And when you say bolus, it needs to be given in 15 minutes, not 999. Some of the Alaris pump, they set it to like 999, and that is at least 1 hour, 45 minutes. But we want it in 15 minutes, right? So either you need to use a pressure bag and put it in a pressure bag, and then connect it to your, hopefully you have a cordis or you have a bigger central line, because that is the definition of bolus. You want the fluid fast, okay? And if it's the bolus is not enough, then what do you do next? Okay, so do you want to repeat bolus? And if it's not gonna work, start what? Vasoactive drugs, right? So again, guys, with vasoactive drugs, there's a critical thinking again in here. If my blood pressure is low, 70/45, but if my heart rate is 130, we all know that there's a medication that is intended for heart rate of 130. I mean, you can give an alpha, right? So alpha, you're not really touching the heart, you're just touching the vessels, such as your neosynephrine. So your neosynephrine is the medication that you need to ask the doctor if the heart rate is 130 and blood pressure is low. All right, you need to pay attention to that, because if the doctor don't know anything about the heart rate and he gave you an order for Libofed or dopamine, then it creates more problem. It's not good, because dopamine can increase your heart rate big time. Libofed is, at least it can still increase your heart rate, but there are patients who are very sensitive, then of course it will. Then you're just wasting the medication. Start with Neo first and see what happens. All right, so that's your S-bar. And speak up for patient safety. So speak up for patient safety using CUS. So what is CUS? C is I am concerned. So concern. So what are your concerns? So, hey doc, I'm concerned. I saw that you did not wash your hands. I'm concerned that we might introduce infection to your patient or to the patient. I'm uncomfortable. I'm really uncomfortable right now because we're planning to give, or we did not do a timeout. We need to do the timeout before the procedure. So you are uncomfortable for patient safety. S, there is a safety issue. So stop. I saw a safety. There is a safety issue right now. We did not do a timeout. So these are the things that you need to use. All right. Well, I hope this helped. I mean, whatever I shared you, I know there's a lot, but at least I was able to give you an overview of what do we do as a nurse, especially if you're a brand new nurse in the acute care or in the hospital and you're looking for some ideas. What do we do at the bedside, especially in the critical care area? If you're a med-surg nurse planning to come and join us in the ICU, this is what I'm telling you that we're doing. All right, thank you.